ahead and get started. Good afternoon, everybody. My name is Erica Saylor, and welcome to the Life Unites Us March webinar, Exploring Life Unites Us Data. We're going to start today by covering a few Zoom housekeeping items, and then we'll move on to a little bit of information about Life Unites Us, and then we will hear from our presenters today about their research. And after we've heard from our speakers today, we'll have time for questions at the end, and then we'll wrap up. This is just a reminder that if you have questions, please enter them into the Q&A feature and not the chat. It's just easier to kind of filter through things that way. If for any reason you get disconnected from Zoom, please try the original link. If for any reason you can't get back in, this webinar is being recorded and will be posted along with the slides from our presenters later this week. All right, some information about Life Unites Us. Life Unites Us is a project developed to reduce stigma around substance use disorder, and this is done by using a people-forward approach that aims to connect individuals through stories. Through research and practice in anti-stigma work, we have found that connecting people through their stories and similarities can and will reduce stigma. In order to do this, the team records stories of community members across PA, stories of both personal recovery as well as allyship to someone in recovery. These stories are then produced and featured on the Life Unites Us website and social media platforms. The intent is by sharing these stories of hope and resiliency, we can prove that recovery is probable, reducing stigma makes recovery more likely, addiction is treatable, those living with an addiction are just like everyone else, and those living with substance use disorder are so much more than their disease. As I mentioned on the last slide, the campaign can be found online and on social media. Our website features a library of resources that are shared, and these are also shared on Facebook, Instagram, Twitter, and also YouTube, and the links are there on the screen. The great news about Life Unites Us is that you can join us in ending stigma by following and sharing the campaign. If you're part of a larger organization or effort, we would love to invite you to become a partner with us. If you're interested, you can email Ashley Narvaez. I will put her email in the chat in case anybody would like to reach out to her directly. I would also invite anybody who's on today to go ahead and put in the chat where you're from, what organization you're from, or any information you want to share today. And without further ado here, we will move on to our speakers. Today, I'm really excited. I have the distinct pleasure of giving the floor over to 4 of my wonderful colleagues to share research that they're doing with the Life Unites Us data. And I will introduce each of them before their respective presentations. So first up, I'm going to stop sharing here. First up, it is my pleasure to introduce Dr. Övgü Kaynak. Dr. Kaynak earned a PhD in public health from Temple University, an MSED in human development from the University of Pennsylvania, and a BA in psychology from Penn State University. Dr. Kaynak's research lies in the intersection of psychology and public health and focuses on how to build motivation, resiliency, and coping skills to provide people with expanded opportunity towards living safe and productive lives. Throughout her career, Dr. Kaynak has worked to serve vulnerable and underserved communities in collaboration with law enforcement, schools, nonprofits, treatment facilities, advocacy groups, and government agencies. Her current research focuses on risk, stigma and violence, and protective factors, social support, community engagement for substance misuse and addiction. At present, Dr. Kaynak is a co-investigator on a state-funded grant aimed to reduce stigma related to the opioid epidemic. Övgü, I will turn it over to you.
Thank you, Erica. Thanks. Okay, so I am going to start things off today talking about a paper that we published entitled The Opioid Epidemic in the State of Stigma, Pennsylvania Statewide Survey. And as you can see, I have listed my co-authors here who contributed to this analysis and paper. So before I get into this paper, I just kind of wanted to introduce or just touch upon research dissemination, since that's kind of what the focus of this webinar is today. So a goal of the Life Unites Us campaign and overall Pennsylvania Substance Use Stigma Reduction Project is to disseminate our findings to other researchers, policymakers, practitioners, and the general public. And as researchers, we disseminate our work through peer-reviewed publications, academic conferences, and scholarly presentations. And so today, what we're going to do is discuss findings from this project that have been published in peer-reviewed journals and presented in conferences and academic talks. So many of you who've been following along with the campaign for the past few years are familiar with the campaign objectives. Of course, we know that the campaign aims to decrease stigma around those living with OUD and SUD by increasing knowledge, improving attitudes, and increasing support for people in recovery. But before we could launch the campaign, we needed to take the temperature of substance use stigma in the state of Pennsylvania. That way, we'd have a baseline of where we started. So that's what I'm going to talk about today. Now, before I get into my talk specifically, we do a lot of different types of data collection in this project. We've done, first of all, more than one review of the literature. We conduct one-on-one interviews, in-depth interviews. We collect feedback from the community. We also have our large statewide survey that we administer every 6 months. And that's kind of what I'm going to focus on. And I think both Nathan and Chris will be presenting analyses using this same baseline survey. And then Nicole's going to be talking more about the one-on-one interviews later on. So when we constructed this survey, there were no comprehensive substance use stigma surveys out there. So we started by reviewing the current stigma measures that were available. Many of them focused on mental health and HIV stigma. And so we adapted items, from those existing surveys. Some items were modified, some were kept the same. And once we had all the questions, we reviewed them, and as well as the face validity of each item. And some were deleted, some were reworded, we added some additional items. And so we finally landed on a survey instrument that consisted of 73 items that covered public work, policy, and self-stigma. And so that's what we're going to look at today. Now, for this analysis, for this baseline survey, we only examined the public stigma survey items, and part of that was just because of space. We just did not have enough space. A lot of journals have word limits, and if we, tried to present everything in one paper, it would have been too many words, essentially. For this analysis in particular, we used a quota-based invitation system to produce a final data set. It's representative of Pennsylvania's population by region, also separately by age, sex, combined categories. And again, for this baseline survey, our sample consisted of 1,033 Pennsylvania adults. So in terms of analysis, we only, again, examined those public survey items, and we reported the weighted percentage level of agreement for each survey item. We also then collapsed the public survey items into subscales. So we had 3 different subscales: general attitudes, desire for social distance, and then knowledge surrounding treatment availability and effectiveness. And then we determined significant differences in responding across demographic groups, so gender, race, and urban-rural status, and we used multiple one-way ANOVAs for that. So what did we find? And again, this is before the launch of the campaign. So we found some findings that we considered to be positive. So the majority of this sample agreed that the opioid epidemic is a problem in their community. and most agreed that anyone can become addicted to opioids. Some not so positive findings. Many in our sample disagreed that OUD was a medical disorder, and continue to endorse social stigma beliefs of people with OUD. So you can look here, we see that 34% would be willing to work closely with an individual with OUD, and 19% would continue living with an individual with OUD. And one thing I forgot to mention, at this point, both in the campaign and in our data collection, we were specifically looking at opioid use disorder. We had not introduced polysubstance use and stimulant use at this point. And then we had some mixed findings. So the majority agreed that there are effective treatments available, but many were unsure whether specific treatments were effective. So about half of our participants were unsure about the effectiveness of MOUDs like buprenorphine, methadone, and naltrexone. Demographic differences. So what did we find? So first of all, men were more likely to hold stigmatizing general attitudes and then attitudes related to treatment effectiveness and availability. Based on prior literature, we theorized that one possible explanation for why men may express more stigmatizing views than women may be differences in related to empathy. Second, women reported significantly higher social stigma distance or social distance stigma when compared to men. For this, we thought it could be explained by the public belief that individuals who use substances are violent and should be avoided, which might be more salient for women when compared to men. And then we also found that individuals who were 65 and older held higher stigmatizing views when compared to 18 to 35-year-olds. We believe that it could be possible that this association could be explained by younger people just endorsing more liberal views, and then just, being more accepting or holding more accepting attitudes toward individuals with STD. And then finally, we did not find differences when comparing urban and rural participants, perhaps due to the way that we measured urban versus rural in our sample. So what did we do from here? Or what did we conclude? So first of all, findings suggested that OUD continues to be a problem in communities, and stigmatizing attitudes and behaviors were still prevalent in Pennsylvania. Uncertainty remained about the effectiveness and availability of OUD treatment. And then, of course, that evidence-based OUD stigma reduction interventions need to target known knowledge gaps or issues, particularly stigmatizing, related to the particularly stigmatizing views in order to impact the ongoing opioid crisis. So where did we go from here? So first of all, these findings from the baseline survey informed campaign messaging. So for example, if you see a statistic in our static messaging in the campaign, that statistic came from one of our statewide surveys. So not only from the baseline, but as we continue to collect data, that's where a lot of our statistics come from. All surveys post campaign launch include questions about campaign awareness. So moving forward, we made sure to ask people if they were kind of aware of the campaign, if they'd seen the campaign. Also, before the launch of each survey, we review all the items and we add and remove items based on team feedback. One example here is that we added items related to stimulant and polysubstance use in year 2. And this baseline survey has led to multiple presentations, publications, research briefs, press releases, both by faculty, but also by our students. So a lot of our students have been involved, in helping to disseminate this data and present, both locally, regionally, and also at national conferences. And then I'll just finish up by saying our next publication related to our statewide survey is our 12-month survey. And these results have already been disseminated through reports to DDAP and official press releases and at some conferences, so you might already be familiar with them, but I thought I would just include them here. You know, after 1 year, when we looked at campaign reach, 29% of our sample of Pennsylvanians had viewed the campaign. Campaign viewers were more likely to say that prescription opioids can be a problem for anyone, that medication-assisted treatments are effective, that they're willing to purchase or obtain naloxone, that they're willing to live with, work with, or be neighbors with people with OUD, and that they support harm reduction strategies. So that's all I have for you today. I'm going to hand it back over to Erica. Thank you for listening.
Thanks so much, Övgü. Next up, we have Dr. Nathan Kruis. Dr. Kruis is an assistant professor in the Department of Criminal Justice at Penn State Altoona, research associate at the Douglas W. Pollock Center for Addiction Outreach and Research, and director at large of the Northeastern Association of Criminal Justice Sciences. He's also the co-director of Penn State Altoona's Integrated Social Science Research Lab and a member of the Blair County chapter of the Pennsylvania Prison Society. He has previously worked as a research associate at the Indiana University of Pennsylvania Applied Research Lab and as a drug and alcohol counselor in a medication-assisted treatment facility in central Pennsylvania. His research interests include stigma and drug use, guns, gun policy, and firearm legislation, and criminological theory. He received his bachelor's degree from Penn State Altoona and earned both his master's and PhD from IUP. His publications have appeared in journals such as Crime and Delinquency, Journal of Drug Issues, American Journal of Criminal Justice, Substance Use and Misuse, and the Journal of Substance Abuse Treatment. Nathan, the floor is yours.
Okay, there we go. Good afternoon, everyone. Thank you all for joining our webinar today. I am going to talk about a paper that we just published in Contemporary Drug Problems that looked at the relationship between addiction frameworks, social stigma of OUD, and policy-related attitudes toward OUD, such as holding NIMBY syndrome for the location of MOUD treatment facilities. Now, for time's sake, I am going to try to be as concise as I can today and only talk about the key parts of our project. I'll start by giving you some background information on the prior research that we've done in this area. Then I'll move on, talk about our methods, some of our main findings. And lastly, I'll conclude by talking about the implications, both theoretically and practically from this research. So as Övgü touched on a little bit in her presentation, we are currently in the midst of a significant decades-long opioid crisis. Recent data suggests that about 3 million Americans meet the clinical criteria for OUD. Another 500,000 are dependent on heroin. Deaths have reached what the CDC has now labeled an epidemic proportion. We eclipsed 80,000 opioid-involved fatalities for the first time in 2021, and it has increased since that time. Currently, about 75% of all overdose deaths involve opioids and/or prescription opioids and/or heroin. And it's not just our healthcare system that has been seeing the effects or the impact of this epidemic. It's also our criminal justice system. When you look at our arrest data, about 1/3 of all drug abuse violations involve either heroin or opioids, and that is one of the largest categories of arrests that are made every year in this country. And subsequently, many individuals who have opioid use disorder end up in our court systems, in our correctional systems, and data suggests that almost 1 in 5 individuals who are incarcerated today have or meet the clinical criteria for OUD. Just to quantify some of these numbers a little further here, if we look at the data from 1999 to 2021, more than 280,000 Americans lost their lives to overdoses involving prescription opioids, and about 152,000 died from overdoses involving heroin. And unfortunately, too many of us have lost loved ones to this epidemic. Myself, I experienced, I lost 2 cousins last year because of this crisis here. And Pennsylvania is one region of the nation that has been particularly hard hit by this epidemic, as characterized by the number of annual overdose deaths in our state. We've ranked in the top 10, usually in the top 5, pretty much every year for the last decade. And the trend in our overdose deaths has really remained relatively stable since around 2016, 2017. Fortunately, the responses to this crisis have been a little different than the responses that we've seen to previous drug crises. And we've seen the implementation, the adoption, and the use of more evidence-based responses, such as having officers and other first responders carry and administer naloxone. We've seen the implementation of different diversionary programs and policies used by law enforcement departments, where instead of arresting individuals, they divert them into substance use treatment instead. And then we've also seen the use of medications for opioid use disorder be expanded in certain areas, such as buprenorphine, methadone, and naltrexone. However, though, that said, these evidence-based responses have really been underutilized on a national scale. And the most recent data that I've seen suggests that only about 1 in 5 law enforcement departments currently has a policy that requires officers to carry and administer naloxone. When we look at diversionary policies, it's fewer than 10% of all law enforcement departments in this country are actually using one of these strategies right now. And when it comes to MOUD, it's really jurisdictionally dependent whether or not individuals with OUD who come in contact with the justice system have access to all 3 forms of these treatment. And data suggests that only about half at best of everyone in the community who has OUD has access to all 3 forms of MOUD. One of the biggest barriers to fighting this epidemic is stigma of OUD. And some of our prior research has found that stigma of OUD is correlated with negative attitudes toward the use of medications for opioid use disorder. Some of our earlier research also found that stigma was present in samples of first responders and that it influenced their anticipated behavioral responses to opioid overdoses. And quite literally, individuals in our study who held high levels of stigma were less willing to provide a full range of services to someone who experienced an opioid overdose. And there's also an increasing number of studies who have found that stigma of OUD presents a significant barrier to treatment availability, initiation, and utilization. So building on this research, what this paper did that was published in Contemporary Drug Problems was looked at the empirical relationship between addiction frameworks, opioid-related stigma, and policy-related attitudes. And by addiction frameworks, what we mean there is one's belief about addiction. Do you see it as a moral failing, or do you see it as a medical issue? And we wanted to see how that predicts opioid-related stigma, which in turn can influence different policy-related attitudes or responses to the opioid crisis. And some of our key outcome measures included having NIMBY syndrome, not wanting to have opioid treatment centers near your house or in your backyard, support for more punitive treatment of OUD, and then support for employment discrimination against individuals who are in recovery and are prescribed MOUD. So data for this study came from the baseline study that Övgü just talked about. And again, just looking at our variables here, really focusing on the relationship for between addiction frameworks and stigma of OUD, how support for the disease model of addiction can serve as a predictor of stigma of OUD, which in turn can predict these different policy variables that we were interested in looking at while controlling for a host of demographic and other relevant variables such as drug use history, both directly as reported by participants and then vicarious that they experience through their family and through other loved ones. So the next 3 figures that I'm going to show you are images that I've snipped directly from our paper. And this first one here is looking at the path analysis, predicting or showing how support for the disease model of addiction, believing that addiction is a disease, associating with medical components, how that is actually a negative predictor of public stigma. Put another way, not supporting the disease model of addiction or seeing it as some form of a moral failure is a positive predictor of stigma of OUD. And that in turn shapes, in this model here, one's support for NIMBY syndrome, or not wanting to have MOUD treatment facilities located near their home. The second image here is looking at a similar path, only here the outcome measure is support for punitive treatment, so favoring criminal responses as opposed to medical responses for individuals who are opioid use dependent. And again, we find a very similar model here that supporting a moral model of addiction is a positive predictor, whereas supporting a disease model of addiction is a negative predictor of stigma. And then stigma in turn shapes positively support for more punitive treatment or punitive responses toward individuals who have OUD. And then finally here, we're looking at supporting employment discrimination for individuals who are in recovery and are prescribed MOUD. And we find a similar path again, that support for the disease model of addiction is a negative predictor of stigma, whereas support for the moral model of addiction is a positive predictor. And that stigma in turn predicts support for employment discrimination. So what does all this mean and why is it important? Well, empirically, it's showing us that there seems to be an indirect relationship between one's addiction frameworks and their other policy-oriented attitudes toward the appropriateness of responses to the opioid crisis that is mediated by stigma. So what that means is that our beliefs about addiction seem to influence the level of stigma that we place onto individuals that have opioid use disorder. And that in turn, the stigma, influences our beliefs about the appropriateness of certain responses to the opioid crisis. Practically, what that means for us is that if we want to fight stigma, we really need to start by addressing these addiction frameworks, by attacking that moral model of addiction and getting people to understand that addiction is it's a disease and that there are medical components to it and that it can be treated like any other disease. And it shows support for campaigns like the Life Unites Us initiative, where we're going out there and we're trying to get these types of messages out in the community to alleviate these misperceptions, these negative beliefs and stigma associated with OUD. In terms of future work, we're looking to expand this into other regions and then incorporate longitudinal data into our analyses so we can further control for the temporal ordering of some of these relationships. Thank you.
Thank you so much, Ethan. All right, moving right along here. Our next speaker is Dr. Christopher Whipple. Dr. Whipple is an assistant professor of psychology at Penn State Harrisburg. Dr. Whipple earned his PhD in community psychology from DePaul University. He previously worked as a project director for an NIH-funded grant to develop, implement, and evaluate a culturally adapted violence and suicide program for urban African-American adolescents. His research focuses on exposure to community violence among African-American adolescents, adolescent involvement in the juvenile justice system, and developing and testing preventative interventions to reduce violence and associated outcomes. He's particularly interested in the use of community-based participatory research methods to develop preventative interventions. Chris, I will turn it over to you.
Great, thanks, Erica. Hi, everyone. Thanks for being here today with us. I'll share my screen. Let me see. There we go. Erica, you can see that, right?
Yep.
Perfect. Okay. So today I'm going to be talking about some of the work that we've been doing with our rural counties. We're really interested in understanding what stigma looks like in rural counties, and specifically what harm reduction looks like. What's the level of support for harm reduction strategies in rural counties, and how does stigma kind of affect support for harm reduction strategies. And so for this study, we're going to be looking at stigma and support for harm reduction strategies, specifically for people in rural areas. Nathan and Övgü already touched on a lot of the introductory stuff about stigma, about opioid overdoses and opioid use disorder. So I'll just touch briefly on some pieces specific to our rural areas. In rural areas recently, they've seen a significant increase in opioid overdoses. Over the past few years, there's been about a 700% increase in opioid mortality rates in rural areas. So that's a huge increase in people who are dying due to overdose with opioids. We know that for every fatal overdose we have, there are a number of other non-fatal overdoses that are occurring. One statistic suggests that for every fatal overdose, there are approximately 30 non-fatal overdoses, which really highlights the need for treatment, for recovery resources, for additional resources to support people with opioid use disorder, particularly in these rural areas. Some of the research that we have about stigma in rural areas suggests that stigma may be higher in these areas, and that stigma might introduce different barriers to accessing treatment, whether it be actually having treatment in your community, opportunities in your community, or stigma from families, friends, and others that makes it less likely that you'll be willing to use those treatment resources that are available. So stigma has a big impact on availability of treatment and recovery resources, and is going to impact the availability of harm reduction opportunities. And so the stigma that we see in some of our rural areas may make it less likely for people to be able to utilize the resources that will help them avoid these fatal overdose experiences. So in our current study, we're trying to understand two things. First, what does stigma actually look like in rural areas? We have an idea that it tends to be higher, but is it higher across the board, or is there some differences or variability in the types of stigma that we're seeing in rural areas? And then how do those differences in stigma influence people's willingness to support use of harm reduction strategies, things like overdose prevention centers, syringe services programs, fentanyl test strips, or Narcan distribution. And so using the data that Övgü and Nathan described earlier, we took a look at these differences. So we used the baseline data on our statewide stigma survey. So this is data that's coming from before the launch of our Life Unites Us campaign. Of the about 1,000 people who responded to that overall survey, about 251 were from rural counties. You can see kind of the breakdown here. Just under half were women, and about 95% reported they were non-Hispanic white individuals. The average age was about 50 years old for people who were in our rural counties. We asked a number of items that Övgü touched on earlier. For this study, we focused on 10 items from our public stigma questions. Some of the questions are included here. People who are addicted to opioids are junkies. Opioid addiction is a medical illness like diabetes, arthritis, or heart disease. And I would be willing to have a person with OUD as a neighbor. We also used 4 items to measure support for harm reduction strategies. All the items had kind of the same question. It was, this strategy should be available as a harm reduction strategy in Pennsylvania. And participants could either disagree or agree on each of these different strategies, being overdose prevention centers, syringe services programs, fentanyl test strips, and Narcan distribution. For those that are really interested in stats, which I imagine is not a huge portion of the population, but it is for me, this is how we analyze the data. We used latent class analysis to understand groups of stigma or types of stigma that we see in our rural counties. And then analysis of covariance to examine differences in support for harm reduction based on the type of stigma that people reported. So our first, this graph here shows the different types of stigma that we saw in our rural participants. So each of these lines represents a different group of participants who responded in a similar way to our stigma questions. So we asked 10 questions on public stigma. About 6 of them were about attitudes and beliefs regarding OUD or people with OUD. And then 4 questions were more behaviorally related. I'd be willing to have various relationships with people with OUD or people in recovery. Like I'd be willing to live with someone who is an active addiction. I'd be willing to work with someone at a job. I'd be willing to have them as a neighbor or continue my relationship as a friend with them. And so in this graph, the axis over here is kind of the probability that people would give a stigmatizing response. So higher scores on this show that more people in each group are giving stigmatizing responses for that item. And then you see the items across the bottom. This big red line here represents a group that showed high levels of stigma on most of the items. They had higher than average levels of stigma for attitudes and beliefs. And for the behavioral questions, they were very unwilling to engage in those relationships with people with OUD or people who were in recovery. So we call this red line our high stigma group. This blue line is an interesting one. It represents people who had high scores on some of the attitude and behavior questions, but relatively low scores on the behavioral questions or the relationship questions. So you can see here, they tended to be more stigmatizing on questions like people should be able to stop using opioids on their own, or opioid addiction is a medical illness. They weren't very supportive of that idea. They were also more likely to say that a lack of moral strength plays a large part in opioid addiction. So their attitudes and behavior, or attitudes and beliefs about people who use opioids were stigmatizing, but they were very willing to engage in relationships with people with opioid use disorder. So we called this our high judgment. They were more judgmental of people with opioid use disorder, but low stigmatizing behavior group. The yellow line represents people who had relatively low levels of stigmatizing ideas and attitudes, but high levels of stigmatizing behavior. So they weren't stigmatizing in how they thought about people with opioid use disorder, but they didn't really want to be around them as much as other people. So that was our high stigmatizing behavior, low stigmatizing attitudes group. And then this green line is our group that was low on most everything. They had low levels of stigma for attitudes and behaviors, and they were pretty willing to engage with people with opioid use disorder in various relationships. You can see here, we put kind of descriptions of what these different groups are. About 31% of our participants were in the low stigma group. So about a third of our rural participants had low levels of stigma. 32% were in the high stigmatizing behavior, low stigmatizing attitudes group, 16% in the high judgment, low stigmatizing behavior, about 20% in the high stigma group. So we see that there's a wide range of stigma in our rural groups. It's not just everybody in rural counties is stigmatizing toward people with opioid use disorder. Sure, some people are, but a lot of people are supportive. A lot of people are willing to engage in relationships with people who are in recovery or people who have OUD. And there are a large proportion of people who have very low levels of stigma. We then looked at how these groups differed in their support for harm reduction strategies. And so this is for overdose prevention centers. So we asked, how supportive are you of these types of strategies being used in Pennsylvania? And this is the average level of support. So higher values represent more support for that particular strategy. Here's our low stigma group, high stigmatizing behavior, low stigmatizing attitudes. high judgment, low stigmatizing behavior, and then our high stigma group. And you can see pretty clearly people who had low stigma were much more supportive of our overdose prevention centers being used, then followed by the high stigmatizing behavior, low stigmatizing attitudes, then high judgment, low stigmatizing behavior, and obviously our lowest support was from our high stigma group. So you can see here that some of these are different, but not incredibly different. The low stigma group was pretty supportive of overdose prevention centers. The high stigmatizing behavior, low stigmatizing attitudes, people who didn't want to be around people with opioid use disorder, but were they thought positively about opioid use disorder, had less support, but still relatively high levels. This is for syringe support for syringe services programs. You see kind of the same level of support. People are more supportive of this than the overdose prevention centers. But you see here kind of low stigma is the most supportive, high stigma is the least supportive, with the other two in the middle. Again, some of these groups start to get a little closer together, and we see interesting differences between the high stigma group, which has really low levels of support, and those middle groups that might be more supportive overall. This is for fentanyl test strips. Since fentanyl test strips were legalized in Pennsylvania, overall, we've seen kind of an increase in level of support for their use. But this data is coming from before they were legalized. You can see that for the most part, there are high levels of support for fentanyl test strips, except for that harm or the high stigma group. The other groups are relatively close together. So for the most part, people, as long as they don't have high levels of stigma, are pretty supportive of the use of fentanyl test strips. And then lastly, this is our Narcan distribution. And we see kind of a similar breakdown. For people who have high stigma, they're not incredibly supportive of Narcan distribution, but everyone else has pretty high levels. And this low stigma group is very supportive of the use of Narcan distribution as a harm reduction strategy. So to wrap it up, we see that stigma in rural areas is not this overwhelmingly bad situation. There is a variety of stigma types in rural counties, people who are very supportive and very understanding and want to work with and engage with people in recovery and people with opioid use disorder. There are people who have some stigmatizing ideas and attitudes, but they want to work with and support people relationship wise. There are others who are kind of the opposite. They don't think bad about people with opioid use disorder, but they don't want to engage with them. And then there are some people who have high levels of stigma. Generally, people who had more stigma were less supportive of harm reduction, but there were some differences. Some of those middle groups, people who had high levels of judgment but low behavioral stigma, people who had high behavioral stigma but lower attitudes, may be more supportive of harm reduction strategies. And so we can use some of this information to understand how to better target some of these groups to reduce stigma and increase support for harm reduction. Overall, pushing those high support strategies like Narcan distribution and fentanyl test strips is a good strategy. There's high levels of support across the board for these strategies being used. For the other strategies like overdose prevention centers and syringe services programs, maybe starting with reducing stigma and building support for these strategies would help to increase the implementation of them later on. That's all I have, so thank you very much.
Great, thanks, Chris. All right, and last but certainly not least is Nicole Sturges. Nicole leads the qualitative research team at the Center for Survey Research, Institute of State and Regional Affairs at Penn State Harrisburg. She manages a portfolio of research projects, works with clients on study design and implementation, and oversees research compliance. She also serves as the center's primary focus group moderator, one-on-one interviewer, and lead qualitative data analyst. Nicole received graduate training in survey questionnaire design and qualitative data analysis and has lectured on focus group administration, survey interview techniques, and questionnaire design. Nicole, the floor is yours.
Great, thank you, Erica. So this part of the webinar will share findings from qualitative research conducted to explore the topic of stigma experienced by family members who have a loved one with substance use disorder. The data that I'm going to present today was shared at the Society of Behavioral Medicine Conference in the spring of 2023 and published in the special journal supplement that included all abstracts at this annual meeting. So we conducted 20 in-depth interviews with family members of individuals with substance use disorder. These interviews were conducted virtually using Zoom in order to easily speak with families from across the Commonwealth. The interviews lasted about an hour and were conducted from February to April of 2022. The main goal of these interviews was to explore stigma and the impacts of stigma experiences on families. And additionally, we discussed anti-stigma strategies and messaging, especially for family members. Interview participants were recruited using a multi-pronged strategy that focused on using Life Unites Us partnerships, the campaign's Community Impact Committee and Community Engagement Committee, as well as social media to share and distribute information on the interviews via their contacts and networks. This slide provides a profile of our interview participants. As you can see, most were female and a parent with a child with SUD. Almost 2/3 indicated that their loved one used opioids. However, you will note that 80% said that their loved one used multiple substances in addition to opioids. Participants had loved ones in many different stages of their substance use journey. 9 indicated that their loved one was in recovery. 2 noted their loved one was currently not using, but were not in recovery. 7 had a loved one with SUD that was deceased, and 2 participants shared that their loved one was currently actively using substances. Stigma experienced by family members because of their relationships with someone with SUD is courtesy stigma, and we saw this a lot during the interviews. This stigma occurs when someone experiences negative attitudes or views from others. You can think of it as stigma by association. Participants shared examples of how courtesy stigma resulted in them being treated unfairly or differently because of their loved one's substance use disorder. And parents were particularly impacted and highlighted feelings of judgment, blame, and shame from others. Experiences with courtesy stigma led many family members to feel isolated and withdraw from others, including friends and family, because of their stigma experiences. The fear of judgment or having to talk about or defend their loved ones was so difficult that some parents did not even want to go out in public. Parents also noted that the lack of education surrounding SUD likely also contributed to others labeling, criticizing, and making assumptions about them and their family. This slide highlights some of the powerful stories and quotes from interview participants about their experiences with courtesy stigma. The first quote is from a personal story shared by a parent who wanted to do something in their local community park after their son's death due to substance use, but were told that, quote, this type of thing was reserved for people who were more revered in the community, not for people who died like your son did. Parents also described the overwhelming feelings of judgment and blame they experienced. They noted the perception that they were bad parents or that they did something wrong and failed their child. These stigmatizing views caused many participants to, as noted earlier, withdraw from others and isolate themselves. One parent described avoiding the local grocery store so they would not see anyone they knew due to fears and concerns about judgmental looks or having to talk with others who did not understand what their family was going through. The other type of stigma that we found during our interviews was vicarious stigma. And this is when a family member experiences emotions such as anger, sadness, or pain as a result of witnessing their loved one face stigma associated with their SUD. For most interview participants, this type of stigma was much more difficult than experiencing stigma themselves. Parents discussed internalizing this stigma, which led to devastating feelings of sadness, hopelessness, and isolation. This slide, again, shares some quotes from our interviews, and parents discussed being protective of their loved ones. They noted the pain and anger they felt when their child encountered judgment or shame or disrespect because of their SUD. One mother compared the heartbreaking experiences to the feeling of watching a young child experiencing bullying. And another participant shared a story of their child losing friends because their friends were told not to spend time with them anymore because they were a bad influence or felt they were a bad kid. As one mother summed up, quote, "I'm his mother, and what hurts your children hurts you more." So the impacts of this stigma were felt in multiple ways. The burden and stress associated with their loved one's SUD manifested in impacts to their quality of life. This included tolls on their mental and emotional health. They discussed stress, anxiety, and depression. They talked about physical impacts, including health issues, difficulty sleeping, and weight gain. They also noted financial impacts. This was especially true for parents who were providing for basic needs, transportation, healthcare, and even some who became primary caregivers to grandchildren. And finally, impacts on relationships with friends, their community, and even other family members. This included disagreements about care and support for their loved one, judgment and blame, strains on marriages, and social isolation. This slide highlights some of the impacts described by participants, including unbelievable anxiety, devastating loss of friends and neighbors, and disconnecting from family members, all because of stigma. So what can we do to support families? So while we know support for all family members is critical, almost all interview participants shared that where they found the most care and understanding were from those who had similar lived experiences. Participants stressed the importance of finding meaningful connections with other parents who had children with SUD, and that provided the best source of support and recovery for them. As you can see on the screen, a couple of quotes that we heard from the interviews was, I find being with other people who understand and can support me can be supportive, and that's where I need to spend my time. Education, awareness, and speaking more openly about substance use can help to reduce stigma for individuals struggling with SUD and their family members. Showcasing voices of recovery, like the Life Unites Us campaign, and educating that SUD can happen to anyone can make the public less likely to judge or shame individuals. Interview participants, especially parents, shared that remembering that the person struggling with SUD is someone's family member or loved one reveals the human dimension and connection. As one person said, quote, "It could be any one of us in this position. It impacts everyone." So we're continuing to explore the impacts of stigma on family members. In fact, we're starting another round of interviews shortly. You can visit our website for more information, including a series of research briefs that highlight findings from our data collection efforts as part of this campaign. And thanks so much for listening, and I'll turn it back over to Erica.
Great, thank you so much, Nicole. Let me just adjust things here. All righty. So I want to thank all of our presenters for sharing their research today. This is a reminder, if anybody has any questions, please go ahead and put them in the Q&A feature. I know Dr. Whipple is responding to one that was in there specific regarding harm reduction strategies. But while we wait to see if any other questions filter in, I just wanted to open it up to all of our presenters here if you all wanted to talk about what's the next step or what's kind of on the plate for future research and kind of all the respective areas that you guys are working on within the campaign, if you want to share for anybody. Don't everybody talk at once.
So I will say that we've got a lot of ideas. Some are better than others. And I will open this up because we really appreciate kind of input from experts in the field. And you all have kind of on the ground expertise working with people with substance use disorder. If you have thoughts or ideas that you want us to look into, please send them our way. Övgü mentioned that we're working on submitting some of the results from our evaluation of the Life Unites Us campaign after 12 months. And so that's one of the things that we're working on. We're also working with some of our students on more harm reduction stuff. I feel like Pennsylvania is kind of moving towards providing more harm reduction opportunities with the with making fentanyl test strips legal and some other changes. And so one of our current papers we're working on is looking at how support for harm reduction strategies differs between each harm reduction strategies and the effect that knowing someone with a substance use disorder has on your level of support. So if you know someone, are you more likely to support harm reduction strategies, less likely to support it? And does it change based on the type of strategy? So that's one of the things we're currently working on.
Yeah, and I'll add on to that we're also launching a survey specifically aiming to recruit family members based on, you know, the qualitative results that Nicole just shared and some of the feedback we've been receiving from our community impact committee. And so that's going to be, again, targeting family members, but also trying to kind of look specifically at how stigma might differ depending on kind of closeness to the family member, right? So nuclear family versus extended versus knowing someone. So we'll hopefully have some results for that after the summer.
Great. Any other last thoughts here? I know we're at the hour here.
No, but if anybody has any other questions, you can reach out to us. We included emails, I think, in all the different slides.
Yes, and thank you for reminding me, Övgü. So this is a friendly reminder. I did also put this in the chat that the recording of today's webinar, as well as all the slide decks, will be posted to the Life Unites Us data dashboard at some point this week, likely tomorrow, but it might be a little bit more towards Friday. What's today? Wednesday, Friday. So with all of that being said, we can wrap up. I do just want to remind folks that when you close out from today's webinar, you'll be redirected to a very short survey. We would really appreciate everyone's feedback on the webinar today and also what we can target for future webinars. And with that, I hope you all have a great rest of your day and take care.